am Dr. Abhishek Chopra, working as Senior Consultant in the Department of Neonatology and Paediatrics at Cloudnine Hospital, Punjabi Bagh. Now I want to describe one success story. So nearly 1 year ago, a 23 weeks old baby weighing just 520 grams and the size of the palm was born at our hospital. So we received this baby in a special polyethylene wrap. So this wrap is used so that we can maintain the temperature of the baby. So as soon as we received the baby was not breathing. He was very gasping breathing. So what we did is we directly put the endotracheal tube into the trachea of the baby and we started ventilating the baby. We shifted the baby to our NICU on a special transport incubator and transport ventilator. Then the baby was connected to the ventilator. So now what are the challenges which we face during the ventilation of such small babies? So the baby's weight was just 500 grams. So you can imagine how small the lungs will be. If the baby is weighing just 500 grams, the lungs are going to be very small. And we all know that lung is one of the most crucial organ for the baby. So we wanted to be very perfect for the management of our ventilatory strategies. So we targeted a tidal volume of just 5 ml per kg for the baby. So that is around 2.5 ml for the baby. So we knew that if we are going to deliver around 2.5 ml tidal volume to the baby's lung, the lungs are not going to get damaged. So in this BPL Leoni ventilator, we had the option of starting from the tidal volume ranging from just as low as 0.1 ml. So we started with a tidal volume of 2.5 ml. So the next thing is that we had to give a special medicine which is called surfactant. The surfactant helps to open up the lungs of the baby. So the problem with this medicine is that after giving this medicine, the lungs improve rapidly, and so if we don't titrate the ventilatory settings, so excessively large amount of volume can be delivered to the baby's lungs, and so that can be detrimental for the baby. So to overcome this abnormality or the problem, so what we used is called as the volume guarantee mode of ventilation. So we were sure that if we had switched the volume guarantee mode of ventilation on, so whatever the medicine was given, even if the lungs improve, we will not be delivering more tidal volume than 2.5 ml per kg. So we stuck to our goal, that is maintaining a tidal volume of around 5 to 6 ml per kg. So this baby was around mechanically ventilated for first 3 weeks of the life. So as the baby improved, his lungs grew, his breathing also became better, and his brain also obviously grew. So he started to have good spontaneous respiratory efforts. So the next step which we wanted to do for this baby is to pull out the endotracheal tube, because this is a foreign substance and the foreign substances are dangerous for anyone, and more so for these small premature babies. So we wanted to take out this tube and just put non-invasive ventilator through a nasal mask. So we did not have to shift to another ventilator. So what we did with the similar circuit, we just used a nasal interface and we started the nasal intermittent positive pressure ventilation. So what we were initially doing with the endotracheal tube, we later subsequently did with the use of the nasal mask. So baby did better with this modality also. So baby remained on this ventilation through mask, which is called as non-invasive intermittent positive pressure ventilation, for around next 3 to 4 weeks. Then baby again became better. His weight started to improve, his lung condition also improved, he started to tolerate feeds. So the next step was that we knew that now the baby is having good spontaneous breathing efforts. So we wanted to further reduce his breathing support. So what we did was we shifted the baby from non-invasive positive pressure ventilation to the CPAP mode. So what is CPAP mode? So CPAP is continuous positive airway pressure. So in this modality, baby is breathing spontaneously. We are just providing some kind of baseline support to the baby. So it was very easy with this ventilator. So the interface remained same, the tubings remained same. We did not have to change the ventilator. So what we needed to do was after clicking the NIPPV button, now we had to click to the CPAP button. So that is what we did. So it was very smooth transitioning from the nasal intermittent positive pressure ventilation to the nasal CPAP modality. And subsequently the baby was also shifted to nasal high flow cannula and later weaned to low flow oxygen cannula. When we discharged the baby, so baby was around 4 months old and the baby weighed around 3 kg, and baby was discharged on low flow oxygen therapy. So the survival rate of such a 23-week-old baby in our Indian scenario is maybe around just 5 to 10%, and we were successfully able to save the this such a small baby, and the key important things which are helpful in saving such small baby is the importance of ventilation and nutrition and infection prevention. And so this ventilator helped us a lot in providing definite tidal volumes, using volume guarantee mode of ventilation, having all both the invasive, non-invasive, that is the nasal IPPV, nasal CPAP and nasal high flow cannula therapy at one go. For the successful outcome of the baby, I am thankful to Dr. Manisha, my senior residents, the Department of Gynecology and Obstetrics, and all my nursing colleagues and the entire hospital for the successful outcome of this baby. The ventilator was supplied to us by the BPL technology, and we are fully satisfied with the sales and application support which has been provided to us.